All right, start over. All right, this is today's CME code, WAFDAR. So on Sunday, we had a wonderful residency graduation. Thanks to Suma, Chris, and Gina for setting it up. And there are our wonderful and beautiful graduating residents. And here are our terrified and young incoming second year. So congratulations to all the graduates and welcome to all the new folks. On the research roundup, Suma and Elijah wrote a review article discussing the challenges to diagnosing neurosarcoidosis, probably, addressing people like me who've never been able to do that. I hope one part of their report was never obtain an ACE level because it's meaningless. Was that in there, Suma? Okay, good. Wayne was part of a team that looked at the burden of neurologic diseases around the world and suggested measures to combat them. What does Dorland love about neurology? He loves that it's a constant puzzle that actually matters, unlike the Rubik's Cube. But like if you've never solved the Rubik's Cube, it probably matters. I read a story of a guy who spent 10 years, almost full time, trying to solve it, and he eventually did. And they compared that kid to someone like Chris's son who can do it in a minute blindfolded. And once you read that, you realize that not all brains are the same, right? Not all brains are the same. That doesn't make one smarter than the other. It just means they're different. Hillary Yu, of course she does. She always goes above and beyond to help her patients. And that's why Hillary's great. Portraits today, after this, all of you at home have about 20 to 30 minutes to get in to be in one of these headshots. This year I have a little more hair than last year. It's at the usual spot. This day in science. So we'll start with a couple. So Thomas Edison filed his patent for the light bulb in 1899 on this day. This was the birthday of Virginia Apgar, of the famous Apgar score. And Carl Lashley was born on this day in 1890. Some of you might say, well, who the heck was he? So Carl Lashley was an early brain function that certain parts of the brain did certain functions. Usually mostly rats. He would take out pieces of their brain and see what they had difficulty learning or doing. But he fell apart in the area of memory because he couldn't find a part of the rat's brain that he took out and it wouldn't remember how to cross a maze. And so he went down as one of these people who felt the whole brain, at least parts of it, for learning and memory were all about the same as each other. And it all mattered how much brain you had left. But then came along Wilder Penfield, who actually during surgery stimulated parts of the brain and people had memories, childhood memories that were very detailed. And then finally with Scoville and Brenda Milner and patient HM, it was clear there was a localization, but Lashley was a very important person. And what you might say is, oh, what about Broca and Wernicke? Hadn't they established localization in the brain? Well, they had, but it was written in German and people kind of forgot about it. Yeah, so things can be discovered more than once. All right, again, today's CME code and a corker of a case, a stem winder, Dr. Hussein Al-Shammari, who's a neurocritical care fellow, and after this year is going to go join the Death Star across town in their ICU. So Hussein, why don't you take it over? Will, can you give Hussein a share screen? I have to stop. Oh, shit. There you go. Sorry. Stop share first. It's hard not to focus on this one. All right, here we go.
All right, good morning. Can everyone hear me?
Yep.
Hi, everyone. This is Hussein Al-Shammari. I'm a second year neurocritical care fellow, and I wanted to present a quick case to you just to entice you a little bit. This is a patient who presented to the medical ICU, a 46-year-old female. She had a past medical history of ADHD, mood disorder. It was found down by her husband, and called EMS, presented, and was brought to the hospital. Just a little bit of background about her. Over the past 2 years, she has lost about 100 pounds. all through diet and exercise without the use of any supplements as per the family, including the patient's mother and the husband. She doesn't smoke, but she drinks about 3 to 6 vodkas drinks daily, and that's her standard habits. She doesn't do any illegal drugs. Upon EMS arrival, she was hypoxic to the 80s, hypoglycemic to the 20s, and the thought is that she has overdosed at this point. So EMS administers 300 cc's of D10 as well as Narcan, but the patient exam did not improve. Upon arrival to OED, she was hypotensive and hypoxic. Her GCS was 3 at the point, and patient was intubated for airway protection. Her immediate labs afterwards showed concern for acidosis 7.26 due to hypercarbia, slightly elevated lactate to 4 with a transaminitis and an ethanol level of 63. Her urine toxicology at this point was positive for amphetamine and benzodiazepines, as well as the alcohol, and patient was admitted to the medical ICU for drug overdose. Her CT head and CT angio head and neck showed no acute abnormalities at the time. She was given fluid, started on broad spectrum antibiotics for the concern of infection or encephalitis, and admitted to the medical ICU. This is her tox screen. As you can see, she was positive for the benzos, but she does take Xanax for her mood disorder, and positive for the amphetamine, but she takes.
Hey, yeah, yeah.
And she takes amphetamines for the ADHD. So it did not add up the presentation for the patient. This is a video that I want to share with you. So as soon as the patient arrived to the ICU, this is what was witnessed. This video was with permission from the husband. And as you can see, she's having rhythmic movements with her bilateral upper extremities, first subtle. And I hope you could see the tongue fasciculations there. These movements did worsen with stimulation, and there was a concern about Serpent's component as well. And because of the concern for seizures, patient was
ridiculous, but you have what you're saying.
patient was given.
Can everyone mute, please, especially Will? Thank you.
Patient was given multiple doses of Ativan, to a total of 8 of Ativan, loaded with Keppra 4.5 grams. And since she was already intubated on propofol, a bolus of 100 microgram was given until cessation of the clinical activity. Immediate labs showed that her finger stick was still 47, and patient was started on a D10. This MRI, unfortunately, was done later in time. But I want to share it here before I reveal the diagnosis. And as you can see, this is the restricted diffusion sequence. And you could see cortical, subcortical, as well as corpus callosum enhancements all throughout her brain, and as well as in her brainstem as well. Because of when we went back to her glucose, they were significantly low the whole time. So we actually checked the C-peptide, and the C-peptide was 0.5, and your range is about 0.9 to 4.5 on the normal. We also sent for an insulin level, and that was about 5 times the higher normal level for this patient. And at this point, the diagnosis has changed to exogenous insulin administration. With concerns for self-harm or inflicted harm on the patient from a family member or someone else. Immediately, patient was started on D25. She was given methylprednisolone 80 milligrams, and that's for the hypoglycemia, as well as the glucagon challenge. And this was as per the endo recommendation. I already showed you the MRI. Afterwards, obviously, we have contacted the Durham Police Department, and it's still an open investigation. Multiple discussions took place with the husband, who also happened to be a healthcare worker, in regards to insulin administration, or the patient was taking it herself, or she was getting the help of her spouse. My mom also happened to be a judge, and there has been a search of the house that was done to look for any vials or any syringes, and none were found. Her psychiatrist was contacted, and he did not think the patient was suicidal. Nonetheless, the case that we dealt with here is MRI that showed severe global anoxic brain injury with hypoglycemic changes as well. I think the point that I wanted to make to our team here is the fact that typically for neuroprognostication, especially for cardiac arrest, we do about 3 days plus. But for these cases, it's slightly different. So as per literature and by the guidelines, we actually go up to 28 days. And that's what happened in this case, where the patient was trached and pegged, waited 28 days before final official prognostication, at which point was transitioned to comfort care, and she shortly expired. A few things that came back. It took a while for the Mayo lab to actually come back, but it was the insulin prescription, Lispro, the short-acting insulin. Something I learned from this case, which is the fact that any of us can walk into Walmart and we could pick up insulin without any prescription. And it's part of making it affordable, but at the same time, it's highly concerning to get such a medication without any prescription. Another point that I didn't have time to talk about, which is hypoglycemic, severe hypoglycemia. What point interval does it lead to severe brain damage? In this patient's case, she went to sleep around 7 p.m., woke up at 10 a.m. the next day. We have about 14 hours. And usually we say around 5 to 6 hours is when you actually start to see severe brain damage. The graph on the bottom kind of shows the level in which the neuronal brain death happens, which is around 20. And in this patient's case, she had a 20 multiple times when the EMS arrived. And that's all I have.
All right, thank you very much. For those of you young, you might not remember Klaus Von Bulow, but a lot of us do. It was a very sensational case, maybe in the 70s, where he was accused of killing his socialite wife, who I don't think he killed her, but she was in a coma for a long time with insulin. And I think he eventually got off, as I recall. But yeah, that's a wild case. All right, thank you very much. So to introduce our grand round speaker is Chris Eckstein.
So I'll be brief today since we're a little tight on time with some of the technical difficulties starting. But good morning, everyone. Welcome to Grand Rounds in our next series of chief talks. So as many of you who were at graduation know, Mishy has an interesting background to get here. So she did her training in the US at the University of Minnesota, followed by a master's in health administration. And then has been here for the last few years. So she had an interest in movement disorders very early on. And so a little over a year ago, showed up in my office just before her interviews, completely mute and had lost her voice. I think the day before she was supposed to interview at the place she wanted to end up. Yeah. Despite all that, she ended up matching at Rush, where she's going to be moving to do movement disorders for the next year and actually get to spend some time with her family who already lives there. And she's going to be speaking to us today about your brain on music.
Thank you, Dr. Eckstein, for that introduction. Okay, so today's talk is going to be on music. So we'll talk about how music is used in neurology. Does it work? And if so, how does it change the wiring in the brain? And then we'll talk about some of the challenges of implementation as part of neuro rehab. And finally, look at very briefly at some future directions of research. But before we begin, I'd like for you to listen to this audio clip and keep this at the back of your mind as we move through the talk.
If you had to make a playlist of your life, what would be on it? The music of your childhood, the backbeats of your teens, the music that always makes you cry or fills you with joy. And if, toward the end of your life, your mind and memories were fading away, would this soundtrack help bring them back?
Okay, so music, as we know, is an integral part of every human society across every single human culture. Now, musical experiences have this widespread physiological effect, as we can see here on this figure on the right. Now, there is an increasing recognition of the potential of music to engage multiple different domains in the brain all at once. So motor, speech and language, emotion, memory, not to mention the overall quality of life. While this is not a new idea, research in the last several decades have provided us with a newer understanding of how music does this, both in the healthy and the diseased brain. So how do we use music in neurology? Now, neurologic music therapy differs from the traditional music therapy, which is simply listening or singing, whereas neurologic music therapy utilizes the different elements of music, so melody, rhythm, timbre, pitch, and so on, to then create and integrate new neural pathways to assist with recovery. So in a sense, the fundamental basis for neurologic music therapy is that our minds and our bodies are hardwired for music. Now, this is a really busy slide, but I put it in here just to show you the vast a number of therapies that we have available, and it surprised me when I first learned of it. But broadly speaking, the content of music can be delivered either passively or with more active engagement, like singing, playing an instrument, dancing, or even composing or improvising. And then I've highlighted some of the most frequently used ones. And I'll show you examples of these. So melodic intonation therapy, for example, is where you use the melody of a song to help with the speech. So typically used in patients with severe speech deficits, and use that melody to associate with a phrase for better intonation and recall. Rhythmic speech cueing or rhythmic auditory stimulation is typically where you use an external rhythm or a tempo to then entrain your gait and your speech. And then patterned sensory enhancement is simply where you use the scale of the music to determine how your body should move in space. And so this utilizes the scale or the pitch. And so as that goes up, there's an upward momentum. As that goes down, there's a downward momentum of movement, typically used for non-rhythmic movements like sitting to standing or grasping overhead. And just wanted to show you brief examples of these. So rhythmic auditory stimulation, this is in a TBI survivor, and you see his walk after 4 weeks of physical therapy here. And now you see him walk to the rhythm of the music. Okay. And the second video is that of a stroke survivor with severe speech deficits. And we look at melodic intonation.
Try it again.
This is just singing.
I'm Peter.
This is melodic intonation.
I'm Peter. I'm Peter. How are you? How are you?
After 16 weeks of therapy.
Hello, I'm Peter. How are you? I am good. Thank you. How are you?
Okay, so we've seen all of these techniques, but is there any evidence that it works? Now, music has, and rhythm in particular, has been used across all subspecialties of neurology. And so we'll take a look at some of these, starting with stroke. So this figure on the left is from a meta-analysis that was done on studies looking at upper extremities, specifically hand functions in subacute stroke survivors. And I'm just showing you results from 3 different studies, which use the Action Research Arm Test score to measure hand function. And all 3 studies showed a statistically significant improvement after 12 weeks of music intervention, as you're seeing in these dark blue blocks here. This 4th study is from a separate study that looked at rapid improvement in the timing of a keyboard task. And you're seeing the timing on the y-axis here. And as you can see, there's a really fast learning curve here after the first couple of sessions, and then progressive improvement, almost reaching that of the healthy participant here shown in this gray block. And then this 5th study is basically showing the use of a music glove here, which is a sensorized version of a highly engaging video game called Frets on Fire, built on, inspired by the Guitar Hero. And it requires you to make strumming movements and isometric gripping movements and so on. And what the study did was compare the use of a music glove with 2 other traditional therapies. So one was the isotrainer, and the other was desktop exercises with a therapist. And this study looked at hand function using a box and block score, and then a 9-hole peg test score. And what they found after 12 weeks was statistically significant improvement with the use of the music glove here. And this is just the same thing. It just shows the gain over time with about 8 weeks of intervention. What about Parkinson's? Well, the study on the left, I wanted to highlight because this was one of the very earliest studies done in 1996 by Michael Thout, who's also known as the father of neurologic music therapy. And he published this in the Movement Disorders Society Journal. And what they looked at was 22 Parkinson's patients and looked at the improvement in gait velocity after training to the rhythm of a metronome. And what they found after 12 weeks is a significant increase in gait velocity, which was sustained for about 4 weeks. Now, we know now that this is true, is that for sustained benefits, you need to have repeated exposure. Similarly, this study on the right, I wanted to highlight from amongst many others done on Parkinson's patients because it compared a fixed external rhythm to a more interactive variable rhythm. And we know the danger of using a fixed rhythm every time is, decreases the adaptability and kind of overtrains the brain to a specific rhythm. And Parkinson's patients, may not always be able to synchronize to specific external rhythms. And so that's why the study was important. And what you're seeing here is, 3-arm study. They used a wearable device called the Walkmate that produced a more interactive variable rhythm. And they used an external rhythm with a metronome that was more fixed. And in Parkinson's patients, what they found was the stride times that they measured with the fractal scaling component, that the stride times were significantly higher than when using with the variable rhythm than when using a metronome. So now I wanted to highlight these studies because external rhythmic stimulation has now opened the doors for newer research domains into wearable devices, virtual reality platforms, and so on. It's a whole new talk in and of itself. And then Parkinson's Speech, this trial out of Melbourne in Australia, I wanted to highlight this is because it's, of course, one of the first adequately powered controlled trials done. And also because it looked at 2 different dosage levels. So what you're seeing here is the dark circles are the weekly intervention groups, and the white circles are the monthly intervention groups. And so what they looked at the end of 3 months is that for the singing group, the weekly singing group, both for the weekly and the monthly, they had an increase in vocal intensity that you are seeing here on the y-axis, but you also see a dosage effect where the weekly group on an average had about 6 decibels higher increase in vocal intensity than the monthly group. And these numbers were actually comparable to the LSVT loud, which is a specific speech therapy that they use for Parkinson's. And then this other study, which is a more recent one by Alex Panteliot and his group out of Hopkins, theirs was a little different. What they did was divide the group into 2 groups. The first one, designated as S in the blue boxes here, had the singing intervention, which was weekly. The singing intervention happened first for a period of 12 weeks, followed by a discussion. And then the orange boxes, or the group D, had just weekly discussions first, followed by singing. And what they found was that the group that had 12 weeks of music training first had a significantly larger increase in the vocal intensity than the discussion group. But both had results that were, again, comparable, or if not better, than the LSVT loud. This study was done by Deepal Shah Zamora and her colleagues out of Rush, just looking at the effect of music on non-motor symptoms of Parkinson's. And what they found after 12 weekly sessions was a statistically significant improvement in apathy and depression scores. And I wanted to highlight this study because this is one of the very few pilot studies done to study the effect of music on non-motor Parkinson's symptoms. Next, coming to dementia, this is a meta-analysis that was done on about 50 different studies. I'm only showing you results of some, but if you look at this forest plot, you see most of these studies showed statistically significant improvement with a standard mean that was also statistically significant. The important thing about this meta-analysis is that they reported a vast amount of heterogeneity across the studies, with mostly in the amount of intervention time. And what they found was that shorter intervention periods of less than 20 weeks tended to have better results. Similarly, this trial was a single-blind randomized controlled trial. The reason I show this here is because they engaged the caregivers and the nurses of persons with dementia to incorporate music as part of their day-to-day care, and looked at these measures over a period of 9 months. And what they found was statistically significant improvement in depression, in quality of life, and in caregivers' burden as measured by the Zaret burdens interview, but only in the music listening group, not the singing group. We, of course, have many studies that show benefits of both of these interventions, not to mention a large amount of anecdotal data on Alzheimer's disease and music. I'm just showing a very brief clip here from a video taken from the Alzheimer's Research Association that was introduced to me by Erica Cummings, one of the APPs on general neurology. You must watch this in full if you haven't. Okay, next we come to epilepsy. Now, we've all heard about the Mozart effect, which are claims of increase in intelligence if you listen to Mozart. Those are absolutely false, but what is real is that we can use music to treat epilepsy, but not just any form of music, specifically Mozart's Sonata for 2 pianos in D major, otherwise known as K448. Now, the study on the left is from out of Dartmouth by Robert Kwon, published in Nature. And the results of this have been replicated by many, many other studies. And what they showed was when listening to K448 as compared to other forms of classical music, there was a statistically significant reduction in the interictal discharges, but only after an exposure of about 30 seconds or later. As I said, many studies have replicated this result, but we really don't fully understand why. But there was this one group out of Toronto that compared what happens to the brain when we listen to Beethoven's Fur Elise as compared to K448. And what they looked at was the electrical activity of the neurons. And you see these squiggly lines here, which represents the electrical activity, otherwise in EEG language known as the 1/f distribution. And so what they looked at was, while listening to Mozart, these blue squiggly lines are highly unpredictable and therefore having a slope which is much lower than when listening to Beethoven's Fur Elise, these green squiggly lines, which have a more predictable pattern here, and therefore a much higher slope. And seizures, as we know, represent a state of highly synchronous electrical activity. And so what they proposed was that listening to this specific Mozart's composition situates your brain in a more noise-like state and away from a state that might make you more susceptible to having interictal activity or seizures. And now there's been a lot of research trying to prove that that is indeed the case. So I wanted to play these audio clips for you to see for yourself the difference. Let me just put this up. And sorry. Okay, so this is Beethoven. Okay, now let's see if we can determine what unpredictability means in terms of music. So this is K448. So as you can tell, you know, there's a difference in the music structure, and it just sort of makes a little bit of sense to me. I'm going to skip over this slide in the interest of time, but just wanted to throw it there just to show you that music really has evidence across all different subspecialties in neurology. So we know that it works, but why and how does it work? Now, the idea that music changes the brain over a period of time is not new. And so one of the founding fathers of neuroscience, Santiago Ramón y Cajal from Spain, in 1904 wrote about how someone who's practicing music, in addition to the reinforcement of pre-established pathways, is creating these new pathways over time. And now we, of course, have a lot of advanced technologies to show that that is indeed the case. So how does music help with gait training? Well, in the absence of external cueing, so in a normal, healthy individual, the internal cueing signals for movement are generated by the basal ganglia, the supplementary motor area, and the premotor cortex. And these then feed into these motor programs and help us walk. It's a very bird's eye view. But then what rhythmic auditory stimulation does is really promote the interaction of the auditory cortex with one or more of the main motor systems. So the corticostriatal, the corticocerebellar, or the premotor primary sensory motor cortex. And so effectively allowing us to bypass one of the faulty pathways, if there is any, and promoting the activity in the others. Similarly, for speech, how does music help? Well, there was this hypothesis that was first floated by Ani Patel and his colleagues out of San Diego, now, of course, by several others who have added to it. And what they focused on was the overlap in the areas of the brain that process speech and music. And so this figure here on the right, I will not even attempt to explain the figure, but just put it in there to show that there are many, many different areas of overlap in the processing of the acoustic elements of speech as well as music. And the thought is that music actually places a much higher demand on these networks because of the amount of precision that is needed for signal encoding. And so repeated exposure over time then sets the stage for adaptive plasticity to happen. And we now know with the use of functional MRI images and a lot of research into connectivity and network analyses, we now know this to be true. And so before we come to what the functional network analyses has shown us, just wanted to show you, give you a quick brief understanding of what this actually does. And so as you're seeing these dark circles here, these are called nodes or eigennodes in mathematical language, simply representing the fundamental elements of a system. So in our case, the neurons and linked to other neurons by edges or links. And so a group of neurons that are highly interconnected amongst themselves is known as a community. And these communities that are highly interconnected amongst themselves, but not so much to other communities, are said to have high modularity. So why am I showing you this? Well, because it turns out we do not have measures to capture the electrical signals coming out of a single community. But what we do have is the functional MRI, which captures signals from hundreds and thousands of these communities, otherwise known as a voxel. So voxel is just a tiny three-dimensional pixel of brain tissue that contains hundreds of these communities. And we are able to capture signal from those, and those signals are called the bold signals, or the blood oxygen level dependent signals. And it simply means that as the neurons are activated, you have a lot more blood flow carrying more oxygen and glucose. And what we are able to do then is capture the electrical signal from a single voxel over a period of time and compare that to every other voxel that is activated over that same period of time. We are only interested in the strongest signals. And so those ones get a value of 1, and we are seeing the colored boxes, and the rest get a value of 0. And so those are darkened out. And so from here, we apply a lot more sophisticated mathematics to then come up with a functional brain map using fMRI data and a structural brain map using something like a DTI image. So what has this shown us so far? The first thing we've learned is that the brain actually has a default mode network. And what that means is that it's just an interconnected set of regions that are highly active even when we think we are at rest. So it's involved in some very important activities like reprocessing of autobiographic and episodic memory, mind wandering, or what we may call as daydreaming, and then introspection of thoughts directed towards self, and many such functions. And broadly speaking is divided into this dorsal prefrontal, ventral prefrontal, this posterior cingulate here with the adjacent precuneus, and then parts of the lateral parietal. Why am I showing you this? Because it turns out that this is the network that gets activated every single time you listen to a piece of music. Now, so as you can see, music is then processed very widely across both hemispheres. So including sound processing, language and speech processing areas. So the superior temporal, inferior frontal, then you have parts that, of course, the somatosensory and motor cortex, parts that look at attention and working memory, the dorsal and ventral prefrontal cortex. Then you have episodic memory areas, angular gyrus, middle temporal, And of course, the hippocampus precuneus, and then also rewards and emotions like the nucleus accumbens and the amygdala, if you're listening to a song that is associated with really bitter memories. And so the point in showing this really busy slide is that there is something to be gained for everyone listening to music, but the difficulty is that it's very hard to isolate the effects of single networks. And so do we know anything about, whether this network changes the strength of its connections based on the genres of music that we listen to? Well, turns out that it doesn't matter if you're listening to Beethoven, Randy Carlyle, I don't know, Pink Floyd, or even Justin Timberlake for that matter. There was a study that was done by Robin Wilkins and her colleagues out of Greensboro, actually, that looked at 20 different participants and their brains when they listened to these 5 different genres of music, and a 6th one that they designated as their favorite. And what they found was that your favorite music will trigger the exact same activity that other people's favorite music does in theirs. So it does not matter what genre of music you're listening to, but what matters is whether you like it or not. And so what they found was that dislike looked very different from like, and certainly different from favorite. And so if you're listening to music that you don't like, this default network tends to be very disconnected as opposed to when you're listening to your favorite music. And you see here, which I should have mentioned when I was talking about it, is a very similar pattern of connectedness across different genres of music. So this is important because it has implications in terms of what kind of music you're using in therapy. Typically, we tend to go with the popular melodies that not everybody likes. And then this study I wanted to highlight was by Amelia Bonema and her colleagues out of Houston. What they did was create these network-like representations of 21 different participants again. And what she looked at was how your brain looks like when you're listening to your favorite music. And based off of these images, they divided the group into a high modularity and a low modularity group. Now, remember, the high modularity group is the communities are highly connected amongst themselves, but not so much to the other communities. And these communities in mathematical graph theory are very hard to disrupt. Whereas the low modularity communities that are very strongly connected to widespread other communities are much easier to disrupt and create new connections. And so they tried to predict what your brain would look like if you're listening to unfamiliar music. And what they found was that in the low modularity group, you see a lot of new and different connections being formed, whether you're listening to familiar or unfamiliar music. But when you're listening to, but in the high modularity group, you only form these new connections when you're listening to unfamiliar music. Again, this sort of explains why not everybody responds to music therapy and has implications in terms of what kind of music we're using. Now, really, there are lots of interesting tidbits that we've learned over the years. Of course, I just wanted to show you the basic fundamentals of what happens to the brain when we listen to music. And lastly, coming to challenges, there's of course a lack of rigorous, well-powered studies, but now with the NIH's funding for music research as part of Sound Health Initiative, the AAN has come up with a task force to lay down guidelines for randomized controlled trials for research in music. And then the biggest thing is, of course, a lack of clinical expertise and training. We do have about 11 states, mostly on the East Coast, that have a licensed structure for licensing board structure for NMT therapists. And of course, that's kind of the first critical step towards a unique code creation for Medicare and other insurance to then bill for it. And then research future directions. Now, the fMRI images that I showed you, and to my knowledge, there's really not been much imaging studies that looked at the impact on a diseased brain. So Parkinson's in my, which is of interest to me. And so that's what I am going to focus on in fellowship and moving forward, is trying to understand using imaging data, the role of music in slowing down progression, or what happens when we remove the socialization aspect of it. So most of the music therapies tend to happen in a group setting. And then how much music do we really need? Just a quick recommendation, if you haven't watched this movie and if you haven't read this book, you must. It blew my mind. I'm sure it'll blow yours. And then coming to the end of it, because this is a talk on music, I wanted to end it with an audio clip that was my dad's favorite, and something that I have listened to a zillion times over the years, as a way of saying thank you to all residents, staff and faculty here at Duke, and to some very special people in my life, without whose kindness and support I would not have been standing here today. So let's listen to this clip, and then I'll open it up for questions. Okay. Thank you. I think I literally rushed through the talk, so we have questions, time for questions.
It's
Sure.
always been interesting to me that some people like to study while listening to music.
Yes.
Is there any data to say that does help, doesn't help, does help with certain people and hurts other people? What do we know about that?
So I don't know of any controlled trials off the top of my head, but there is a lot of literature on how it engages the attention networks as we study. And so there is evidence that it does that. It boosts the attention networks as we're listening to music. And there's data to show that it does not matter whether it's instrumental or a vocal kind of music. Yeah. I do that. I actually, in Minnesota, I used to study in a coffee shop, which is really busy, but it would help me focus. It's very non-intuitive, but yeah.
Anyone with a question on the internet, please put it in there. No more compliments. So Mishy, I thought the default mode network is activated when you're not doing anything. So why would
That's
it be
right.
activated by music when you're listening to it?
So the fundamental parts of the default mode, using regions like the dorsal and the ventral prefrontal cortex, which are more focused on attention, and then parts of the emotion processing areas. All of these function towards introspection or thoughts directed towards self. And that is what gets activated when you're doing things like that. So the idea is that music tends to activate areas that would promote more attention and more introspection and recalling of fond memories.
What about emotion? Does it activate those areas?
Yes. Mhm. Yeah, which is why some songs can make you cry. Some songs make you really happy. and make you want to dance. So yes.
Even if you can't,
Even if you can't.
makes you want to.
Yeah.
All right. Oh, that's just Will saying we have to take the picture, but we still have time for questions if there are any. So in that dementia study, can you explain that a little bit more?
Yeah.
Like, what did it help with?
So let me put.
Like they did better on a memory test if they had some?
Yes, they looked at MoCA scores, actually. Most of the studies, so it was a meta-analysis that was done, and most of these studies just looked at the MoCA scores before and after.
But were they listening to it during the MoCA, or they
Mhm.
were listening to it and then they did the MoCA?
So about on an average 12 to about 24 to 30 weeks of interventions. And these were mostly weekly interventions across all of these studies.
What about behavior? I mean, that's the big deal in dementia clinic. Just there's some talk about music therapy to kind of calm
Yeah.
people down. What do you think of that?
So I don't know, I mean, I can't cite the studies that have looked at this, but I do know of a lot of anecdotal evidence for behavior control, specifically if you look at that movie, Alive
That's because it
Inside.
was.
But I
it's so
don't know of
powerful for
any.
that person. But I'm talking about someone like me, and I'm going bananas. Okay, you can put something on. I think if you give me chocolate chip ice cream,
We
I'll
can
calm
try,
down. But if
we
you
can
put the
try
music
to
on-
put you, to get you to listen to music.
One of the areas that I'm familiar with is the use of music therapy for prevention of delirium and agitation in
Yeah.
ICU setting.
Yeah.
Where it's been like, I think, very well studied and shown to be useful as an adjunct therapy.
Yeah.
Really?
Again, so I think what the literature shows is like, there are patient population who respond to it. And there are.
How do you know it's not just calming down the doctors and nurses?
That might be true too, like overall reduces the environmental interference that causing the patient to be.
Interesting. All right, Mishy, thank you. I mean, that's very
Thank you.
sophisticated stuff. I mean, you can play it by just put on music and see if they calm down, or you can try to figure out how it works in the brain too.
Yeah.
Yeah. Okay, everyone, pictures next. Thank you, Mishy.
Thank you. Okay, what do I do for this?
I would just like rip it out.
Oh. Yeah, I just disconnected this. Do you have to disconnect something here?
No, I'll
Okay, no?
shut it down.
Okay.
Good job. Sorry, I came in late.
That's okay, as long as you saw my thing.
Yeah, thank you.
The end. Oh,
Lost job.
A lot of them, like it's like patients with ventriculitis.
All right, I gotta see if I can figure out what happened. Of course. Oh,